Welcome to this explainer. We are jumping right into a topic today that, honestly, is way too often shrouded in silence and stigma, and that is pelvic pain. The research and clinical data we're looking at today set out to completely demystify this condition. We want to validate your lived experiences and highlight the real, evidence-based solutions that are actually out there. Healing is absolutely possible. So, let's dive into the science.
Here is the roadmap for our journey today. First, we'll look at the reality of pelvic pain. Second, decoding the medical terms. Third, busting common vaginismus myths. Fourth, the mind-body connection. And finally, effective paths to relief.
Section 1. The reality of pelvic pain. Okay, let's dive into this. It is incredibly, deeply frustrating when medical professionals or partners just dismiss this kind of pain. For decades, the narrative has kind of been that women just have to endure it, or worse, that they're simply imagining it. But looking closely at the clinical data, we can finally validate that what patients experience is very, very real.
This right here is the silent question so many people ask themselves in the dark. Is sex supposed to hurt? Well, the medical data presents a crystal clear answer. While pain with penetration is incredibly common, it is absolutely not normal. The insertion of a tampon, a standard gynecological exam, or intercourse, it really shouldn't hurt. If it does, your body is sending a very real physiological signal that something needs attention.
When we actually look at the numbers, they're staggering. According to the data, 1 in 5 women experience painful sex. Just let that sink in for a second. If you're looking at this research and recognizing your own experience, you are part of a massive group of individuals dealing with the exact same physical struggle. You're not broken, and you are definitely not an anomaly.
To get even more specific, research indicates that vaginismus, which is a specific type of pelvic pain we're going to define in a moment, affects up to 7% of women. Now, what's genuinely surprising about this stat is that 7% is the exact equivalent rate of men who experience erectile dysfunction. I mean, just think about the stark contrast in how much society talks about, funds, and treats ED compared to vaginismus. It's wild.
Section 2. Decoding the medical terms. To really advocate for yourself in a doctor's office, you need the right tools, and vocabulary is hands down one of the most powerful tools you can have.
Now, what's really interesting about this slide is how the research clearly separates 3 interrelated conditions that honestly get confused all the time. First up, vaginismus. This refers to involuntary muscle spasms that make penetration difficult or literally impossible. Next is dyspareunia, which is a broader clinical term for recurrent genital pain during or after sex. And finally, vulvodynia. And this is chronic, localized pain on the vulva itself, the outside tissue. A patient might have one of these or even a combination, but knowing the exact difference gives you a specific, accurate vocabulary for your pain.
Within the specific diagnosis of vaginismus, the medical community identifies 2 main types. Primary vaginismus basically means the pain and spasms have been present from the very first attempt at penetration, so whether that was a tampon, a medical exam, or intercourse. Secondary vaginismus, on the other hand, is acquired later in life, so a person may have had completely pain-free penetration for years, but developed the condition later due to something like trauma, a surgery, an infection, or hormonal shifts like menopause.
Recently, the medical and psychological communities updated their terminology in the DSM-5 to genitopelvic pain/penetration disorder, or GPPD. This was a massive paradigm shift. It essentially merged vaginismus and dyspareunia into one diagnosis that focuses on the actual pain experience. It brilliantly shifts the blame completely away from that outdated, frankly unscientific idea that it's all in a patient's head and formally treats this as a real integrated pain disorder.
Section 3. Busting common vaginismus myths. Unfortunately, because of a historical lack of clinical understanding, there is just a lot of bad advice out there. Let's tackle some of the frustrating myths that still persist.
Oh man, this one. One of the most frequently cited pieces of unhelpful advice in the literature is, just have a drink and relax. It is incredibly common and, clinically speaking, completely ineffective. Research highlights how insidious this myth is because it subtly implies to the patient that the pain is their own fault for simply not being relaxed enough. But the science shows a blunt reality. Vaginismus is a physical condition. The pain is real. The involuntary muscle spasms are 100% real. Actually, getting drunk does absolutely nothing to stop an involuntary pelvic floor muscle spasm. A patient cannot simply relax their way out of a physiological neuromuscular reflex. There's just no way. The research also points to another deeply, deeply harmful myth. The idea that going through childbirth will somehow magically stretch things out and cure the vaginismus.
This specific myth dangerously pushes individuals into terrifying, painful situations without giving them the actual medical support they require.
So the crucial point is that the clinical reality tells a very different story. Childbirth is absolutely nothing to cure the underlying neuromuscular reflex of vaginismus. During a vaginal delivery, nothing is done to effectively reduce the baseline muscle spasm. The data shows that once the baby is born, the fear, the apprehension, and those hypertonic muscles are almost always still right there. It requires actual targeted treatment to resolve.
Section 4. The mind-body connection. To really understand what that targeted treatment looks like, we have to look closely at what's physically happening inside the pelvis.
Pelvic pain is often described in the literature as a perfect storm of physical and emotional triggers. Physical issues, think endometriosis, localized inflammation, or a recurrent infection. These can cause an initial acute pain. In response to that, the body tries to protect itself by tightening the pelvic floor muscles. This creates high muscle tone. So the next time penetration is attempted, it hurts even more because those muscles are locked tight. That pain triggers anxiety, creating this fear avoidance cycle that just feeds right back into continuous pelvic floor hypertonicity. It's a continuous, self-reinforcing biological loop.
To anchor this complex science, medical professionals often use a very relatable metaphor. Patients describe the sensation of an involuntary vaginal spasm as feeling exactly like hitting a literal wall, or getting a sudden, severe Charlie horse in the pelvic floor. Now, if you've ever had a Charlie horse in your calf, you know exactly what this means. You realize immediately that you can't just relax it away instantly. The muscle is biologically locked in a painful spasm. That is exactly what's happening in the pelvic floor.
Section 5. Effective paths to relief. Let's move to and see how this builds into the highly effective, concrete physical treatments and therapies that are available today. Because the genuinely great news from the clinical world is that vaginismus and pelvic pain are highly treatable. One of the gold standards of clinical treatment is at-home vaginal dilator therapy. This involves using smooth, body-safe silicone or plastic dilators to progressively stretch the tissues and retrain those locked-up muscles. Here's how it works. You start by choosing the smallest, most comfortable size. You prepare a calm, totally private environment. You apply generous water-based lubrication. Then, you insert it very gradually, stopping at the exact point of tension, and use deep breathing to literally teach the nervous system and the pelvic floor that penetration is safe and does not have to hurt.
Now, dilators are often used alongside other comprehensive therapies to really maximize results. Pelvic floor physical therapists are absolute game changers here, offering specialized manual release of tight muscles. Then, for severe cases, the medical literature actually points to targeted Botox injections under anesthesia to literally paralyze the spasming muscles, which finally allows that cycle of pain to break. Cognitive behavioral therapy is another incredible tool that helps rewire that fear avoidance loop in the brain. And finally, specialized reverse Kegel exercises help patients learn how to actively drop and relax the pelvic floor.
Which brings us to our final takeaway. The science, the tools, and the specialized professionals are out there right now. The pain you feel is valid, but it absolutely does not have to be your permanent reality. So, armed with this medical knowledge, are you ready to break the cycle and reclaim your pelvic health? Thank you so much for joining me for this explainer, and hey, here's to your healing journey.